Good morning. Energy. It's always great to be last. Thank you for having us here. We are really thrilled to be able to share the project that we are doing here at Atrius. And we come to you together as I'm the chair of internal medicine, which means I'm charged with all things adult primary care. And Kellianne is our senior program manager for adult medicine, adult primary care. And so she's charged with getting everything done the right way, and always does. So that I'm glad that she's here by my side to share this. So the next slide. So a little bit about Atrius, which I'm sure you already know that we are a large ambulatory-based practice in eastern Massachusetts. We really are a primary care dominant practice, although we have embedded specialists. We do not have hospitals, but we do hospitalize people at home. We are a risk-based organization, so managing the outcomes of our patients and optimizing access are mission critical to managing their outcomes and managing our financial bottom line. So next. So we took on a project in the past year. We're just past the 1-year mark, and we're going to be complete with phase 1 this summer. Little background on how we're organized. We used to be in a distributed leadership model, and so every site ran their own operations, had their own P&L. And as I entered the organization, we swung into service lines, and so we had the opportunity to start implementing some standardization with a goal that it would let us leverage greater efficiencies, better outcomes. So we took on a project of schedule optimization, and for us, schedule optimization was about time and access. It was not about productivity, although it is often viewed in that light, but what we really wanted to do is maximize the time of all of our people, whether they are the scheduler or the provider, and we wanted to increase our access to patients similar to what the VA wants to do. So to accomplish this, and I'm going to tell you very high level what we did, and Kellianne's going to give you more detail, but at a high level, we created schedule templates according to service line standards. So we put standardization into the templates. We wanted to make it easier for the staff to schedule. That was a huge goal for us. And we wanted to put the rules that doctors always have on sticky notes that they give to their secretary and embed them into protocols so that there were no more sticky notes, and decrease the burden of the maintenance of the schedule templates, which many of you know maintaining the schedule templates can take quite a few people. And there was a foundation of great tools within Epic that we had not leveraged, and so we wanted to move to a place where we could leverage them. In order to do that, we had to create the standardization so we could get the cool tools. So to start this project, I think one of the things I've really enjoyed about working at Atrius is that really takes a data-driven approach, even in setting the stage for what you're about to do. And so we've heard a lot about the importance of the patient voice. We've used Press Ganey for many years. We used it as one of the means to look at our patient voice. And so we looked at some of the metrics we had about the ability to get an appointment when wanted. And as you can see, the line was going down and not up. We weren't hitting the goals we had set as an organization. We also looked at some typical access standards, such as getting a physical within 30 days. I always have to shudder a little because when I left primary care, mine was 9 months out. So I would have been, but large panels, small people. And then we've been following clinical time utilization before we started this project. We really dug into this space because although we have job expectations and standards, when everything's managed locally, it gets a little challenging to know if you're really on target with people meeting their expectations. So we were really closely tracking and having our local teams manage for quite a while what are the expected hours of said clinician based on their FTE, what's actually in the computer available, what's being booked, and what happens after the dinks and the cancels show up. So we've been following this data, all of which said, do something. Do something. Next slide. We also really spend a lot of time at Atrius we talk a lot and we think a lot. Joe will attest to that. But we spend a lot of time really preparing with one of the stakeholders, which is the providers. And I'm going to pause here for a moment because we've heard a lot about technology today and we've heard a lot about systems thinking. And I really enjoyed from the VA panel yesterday, I could see on the faces of the clinicians and of the patient advocates that it's incredibly, a lot of things could go wrong here. The worst thing that could happen is you don't get what you want. But another thing that can happen is you lose your people. When you're doing a project like this, you can lose patients, you can lose physicians, you can lose your best scheduler. And if you're not aligned in what you're doing, if people don't honestly share why you're doing it, you're going to lose people. We had just come off a run of losing primary care clinicians for other reasons. And so it's really important to us to make sure that the voice of the patient and the voice of the physicians and the voice of the schedules were all in there together. So we conducted a survey across our primary care clinicians in 2018. And what was really joyful for me was what we heard was that they were most aligned with wanting to be sure that their patient had reduced barriers and could get to see them. They were aware that they wanted their teams and their schedulers not to struggle to have that happen. And really what they've been doing in the years of physicians prescribing our schedule is you're just trying to get the flow of the day to be okay. They're just trying to have some control so that you don't have people jammed up and you're late and you're feeling like you're disappointing people. But this work helped us bring the why and the alignment together long before we started jumping into the technology and the operations. So I'm going to hand it off to Kellianne, who really, without Kellianne, this would not have been so as successful as it is. She is going to talk to you about the scope and the approach, and I hope what you're going to hear from us is a little bit less about the tech, we'll share it, but a lot about how do you actually make sure you're successful in this endeavor.
Okay, good morning. So the scope for the work of what we did the first year was really just in the realm of internal medicine, family medicine, and geriatrics. And that was across 26 locations. For us, that totaled 394 providers and just under 900 staff. And I have to admit, I almost wanted to hide this slide after hearing the scale of the VA and the volume that you had. So I feel as though this is a very small fish in a very large pond in comparison. We have some things that are out of scope. I won't spend time on that. Next slide, please. So Jane touched on this a little bit. Really what our initial focus is standardization and understanding what are the fundamentals we had to put in place operationally in order to execute on some of the tools. And we heard a lot of that this week, and I can't stress that enough about understanding how your workflows are and whether they will or will not connect the way that you expect them to around the tools on there. So first thing that we did was we did establish session limit structure. So previous slide I talked about how many different providers we had, 394. That's how many different template options that we had across the system. And we were able to minimize that to a base of 8, keeping in line some key fundamental points of the service line, which for us is internal medicine, around the different visit types that you would want to include in that, the encounter expectations, and different key elements around that. The other thing that we looked at was the appointment types. We saw a wide variety of appointment types that, again, over the years, the structure, people just created things for a variety of reasons. And when we went back to understand the why behind that, we learned that some of them were outdated, some of them weren't necessary in the new structure, and we really pared that down to some key things that we knew that would be forward thinking for things such as My Health and online booking that would align with some other efficiencies with other projects that we were working on. And in doing that, that allowed us to move towards those tools. Next slide, sorry. So high level, one of the things that we had to decide up front was what were the service line standards going to be. So internal medicine leadership got together and we had said, what are the critical things that we have to make sure that are embedded in this process to meet our objective? We have a defined objective of, Jane talked about in the beginning, like we wanted to achieve the improved access, we wanted to improve the experience for the patients, and we wanted to adhere to making the efficiency and the ease of what the schedulers do better while not destroying the lives of the providers. So everything that we decided was in line with that objective and goal, while still maintaining, and I should say our term for that we refer is like those are our critical success factors. Like those are the must-haves in the process. And then beneath that are the things that allow for the flexibility. There was talk yesterday around the importance of flexibility, and I would definitely stress that is there. Well, that's that engagement component to be able to say, these things are here and here's why, but here are the things that you have some flexibility to make some decisions with. The other thing that we put in place was our governance. So we had a steering committee that meets on a regular basis that goes through where are we with the status of the project, and that's been from design to testing to implementation to sustainment, and it included people outside of the service line. So we were trying to think with a broader perspective, what are the things that we're doing that are forward thinking with the direction we're going strategically within the organization, and are the things that we're doing potentially going to negatively impact other areas of the organization and their workflow, such as registration and billing and things of that nature. Next slide. I should also pause and mention here that one of the keys Jane talks about, like, this wasn't possible without me. I would say that it wouldn't be possible without me and a group of people, but in particular the partnership, and people talked about this as well, with your systems folks are extremely critical. And it's not just meeting with the lead and the leadership team. I would highly encourage you to consider they need to be in the room with the design, with your front end users, so that they're hearing the workflows and that they can talk through and collaborate with you around what the designs are and help have those conversations. We had a lot of pivots and beneficial conversations with them in the room to kind of guide us in a different direction because they had the knowledge of the systems. You'll stay on the slide. The high-level elements of what we learned and the way that we approached the rollout of the work. First, data analysis. There was a lot of talk about speak with data and know your purpose. We created for each and every site individual data packets for the providers to help inform the decisions and the discussions that needed to occur locally around what template options they might end up using. And this was things around what is your access, what is your utilization, what's your no-show rate, where people talked about where is the most key over the last 6 months places where most of your no-shows occurred if providers decided that they wanted to build in double books versus the overbooks, things of that nature. A dark spot that we learned along the way, we did do a pilot site, and at that location, the big mistake that we had made, among many that you learn in a pilot site, was that the tools and everything that we had put in place don't mean anything if you don't have the right level of security for the people that are doing the scheduling. And we missed that step, and we put everything in place, and the first week it was a nightmare for the providers because people had the wrong level and were able to blow past everything that was set up as far as session rules, and things were set up in the schedule that was not good. So you also need to plan for mistakes and be reactive to them and resolve them immediately. So our lesson learned was there needs to be a cadence security review, or whatever your system is, to make sure that the appropriate people have the right level and help educate people in that process, which leads to communication. A lot of talk about communication here as well. Communicate 1,000 times more than you think that you need to. Over communicate. It is never going to be enough. Trust me. Communicate in different ways and communicate from the start all the way through. We have done global meetings, we've done emails, we've done face-to-face, we have done site-level communications at every step of the process to try to help ensure. And there are times that I might have had the conversation 5 times with someone and they still look at me when asked the same question. Communication is key. So once we did that, we also did one-on-one provider decisions, and I'll show you a little bit more of what the flexibility and the decision points that they had. The information that the providers gave us then led to the template sessions, and that's really where the work occurred of making the official changes. We pulled the sites offline, and it was, again, a multidisciplinary group of people, and they used the information that each of the providers gave for the sites for us to make the changes live. On average, that took anywhere from 2 to 2.5 days, depending upon the site, the number of providers, and the complexity of their existing templates that would take to make to the transition to the new one. So our sweet spot was really around 2.5 days. And then go live consisted of the on-site elbow support. So training had taken place, we had gotten the feedback, we've done the template changes, and then immediately we were on site with the staff that were doing the scheduling, making sure that they were successful in the tools that we had taught them, that the systems were working the way that they were supposed to, and responding to anything that might have been missed during the prep work. The other thing that we did was multiple sites went live at one time, and we pulled them together for end-of-day check-in calls so that they were collaborating together and hearing the different questions and or concerns that they might have, so that we were doing things in a broader learning realm. Next slide. This here is an example of the flexibility that was built in for the providers. So we did say you have to choose between X number of templates, but within that, their start and end time, whether or not they wanted, 1530s versus 2040s. Minimum was that they had to meet the expectations of the service line, but if they were productive and they wanted to go above that. Modifiers, there was a lot of talk about, can we make it so that someone, age or sex or a specific patient has different timings in there. All of that was able to be built into the process that we utilized in the template design process. Next slide. This here is where we were to what we went to. So our old structure was those blocks that we heard a lot of people talk about, where it was a 9 o'clock, 11 o'clock, and a 12 o'clock, where the only options for a physical for provider X, versus in the new world, the rules are built in behind the scenes, and it still respects I don't want any more than 3 physicals in a session. Some providers are okay with it back to back. Some providers aren't. We were able to build all of that in. So it allowed for the scheduling staff to just be able to type in the actual visit type. And I love the fact that we're moving towards, disease or symptom states in the future, but to be able to help create that, that ease of scheduling. Next slide. This here are some of the tools that are in place for the schedulers. The top corner auto scheduler, that's that function that, if you're looking for a physical, you can type in the word physical and it'll show you a screenshot by your provider or care team member that you have assigned. We have APCs assigned in the system that connect with their care team. It'll search that out for them. The other big feature, the tool that we use is Snapboard. That allows you to see all of the openings in whatever department you're looking at any given time for a particular day. That's really good for same day or acute visits in our world. And then the one click is a great feature more so on the back end when you're looking for follow-ups at the end of the visits for 3 months follow-up, 6 months follow-up. You can click on that and it'll bring you right to that section of the schedules. Next slide. We did enhance our utilization of the mobile app. We had it in place. We have a very high volume of patients that are on it. We just hadn't opened up the ability for them to utilize the system the way that it was intended to do. We were very protective, and we had certain blocks, maybe 1 or 2, if that, with some providers across the system that were available for our patients to see. With this new rules that were put in, it respects that on the patient end. So now what the patients, the schedulers see, our patients see, and it completely opened up the availability for them to be able to look online and compare their schedule. Next slide. Another piece that we've just started working with is the arrival time, and that got to some of the discussions yesterday around recognizing that the face-to-face visit doesn't account for the 10 to 12 minutes that it takes for the support staff to prep the visit and encourage the patient. This here, great tool. If you don't operationalize it, if you don't figure out a way to engage your staff and your patients in the purpose behind this and the intent of the broader visit, it's just a tool that's going to be confusing. Operationally needs to be built in with this. Next slide. This here was just a visual of the schedule. Jean had talked about the fact that we're at the year mark. I think that just the key points I want to call out was we did one site, we did a pilot site, and that was early last year. We had a lot of learnings and mistakes that slowed us down, and we had to go back and do service recovery and resolve some of the things that we missed with that site, build a new model. We did a region at one time, which consisted for us of five sites. Lessons learned from them, got feedback, what worked well, what do we need to do different, modified our approach again to come up with where we are today. And the green arrow denotes where we are. Starting Monday, we go live with the next site template session and go live. And then our last group will be in June, and we will be complete. Last slide. So some high-level results to date. We're 50% of the way done, 14 locations, 198 providers. The Fast Pass is our probably biggest success. That had to do with turning on the functionality with our My Health. And what it does is that any patient that is on a wait list, whether or not there was a future appointment and they wanted to be seen sooner, or for whatever reason the template wasn't available, it will automatically let them know when an appointment is now available following the session rules, and it will ping them either by email or the app. They're able to accept it at that time. It'll cancel the other appointment, which removes the need for manual intervention. And in just the first few months of doing that, we've had just under 2,000 appointments accepted through that mode without human intervention on there, patients being able to use the system. Our online scheduling is already up 37% from the last quarter to this quarter by making this movement, and that's without marketing and even letting them know. That's just patients that are currently seeing it that are being able to utilize it more than what they were. And then I would also call out the no-show rate. We've definitely recognized an impact, and that there is a big difference between the no-show rate of phone calls versus My Health. Our average no-show rate in internal medicine is around 7%. The no-show rate through the My Health is 1.48%. So there's a huge difference. I know I'm going to have one more minute. Okay, so the one thing I wanted to also say is that there was a question yesterday asked to the groups around what would you say the key elements are to implementation, and I just wanted the chance to kind of say from my perspective what I've experienced on that. I was jumping in my seat yesterday. Some of them we've definitely talked about. I'll just highlight. So communication, I cannot stress that enough. Throughout the process, you want to lead with the why and the purpose. You don't just want to tell them what you're doing. They need to understand what it is that you're trying to improve or solve for, and always have your conversations lead back to that. Utilize your data to help inform and engage them in the conversation so that they understand where they're at and where it is that you're trying to go. You want to partner with your systems person and have them be an integral part from start to finish with you throughout the entire process. I heard a lot. I think, Desiree, you talked about engage the people. Absolutely. You need the experts to be there with you throughout the process so that you're not, if you're up here, I used to do the frontline work. I used to do scheduling. I need to constantly be reminded that I don't do it today. Things have changed. I need people that are doing it today to be able to no, we don't do it that way anymore. We do it this way, so that we're not making mistakes in that process. And you need to be open to what their feedback is, even if you've already designed the process, because chances are you might not have gotten it right. So ask the questions, hear what it is that their concerns are, and do one of two things. Either show them how your new system is going to be able to solve for that, but just in a different way, or take a step back, and if you don't have a solution for it, build the solution in. The timeline is not as important as the accuracy of what you're trying to do on there. And then you want to make sure that you circle back to those that you've already gone live with. It sounds like you guys have a staggered approach as well. You want to say, how did it go? What was the training like? Did we teach you the right way? Is it working for you? If you don't do that, you are making the mistake of potentially moving stuff forward that isn't what you intended for it to be. So take that time and have that feedback loop. And then lastly, whatever your training approach is, make sure it's multi-pronged approach. Use handouts, use elbow support training, have your webinars, like the more modalities that people have to be able to understand the process and be able to go back and reference, the better you're going to be at your output. You need to invest the time up front with the staff and the providers and the patients to ensure that they understand, and then you'll get the result that you're hoping for or driving towards at the end. I'll hand it off to. Thank you.
It was a year compacted. Just to end with lessons learned, and the reason Kellianne and I really wanted to do this together is we've taught the synergy between senior leadership and the leaders in the sites and the people who are doing the work is so important. Joe knows that when an angry physician is super angry, they call me. When they're extra angry, they go to Joe, and then they go to the CEO. And the most important thing that we do is make sure that we are aligning our leadership constantly so that we don't get into the habit of, that's a really special doctor, let's just make an exception and treat him this way. Because once you do that, you've tainted everything. We speak in unison when people come back to us. So that alignment, top to bottom, side to side, is really, really important. I think the last reflection, just thinking about, I couldn't help myself when talking about panel size. We've been challenged by extraordinarily large panels. A risk-bearing organization must always grow, and 2,600 heads is our average right now. And when we look at age adjust, we're in the two-thirds of my docs are in the 95th percentile. And so as much as I strongly believe that that impedes access to the appropriate care, I don't know that we have a choice in this country. I'm sure the VA is not. If you have a lot of PCPs, don't tell me that because I'm looking for some. But I'm sure you're challenged by the same thing. I'm sure I could find a few. But what I would really encourage you to do with Cerner, and as you're thinking about team-based care, is put team-based care at the beginning of your design and put virtual care in there too. Because the reality is PCPs are going to have to take care of a larger panel of patients. And we know our patients don't really want to see us for everything. So embedding virtual care into the fabric of primary care and embedding the team into the fabric, which means into Cerner too, because you have to be electronically able to quickly say, that's a virtual post-depression follow-up, that's an appropriate virtual diabetic check-in. The nurse practitioner who's known you for 5 years is a lot better than your physician colleague to see that patient when they're stressed. So continuity for the patient will come when you get the team into the electronic fabric of your system. So I had to end on that because Joe knows how I feel about large panel care. Thank you for the opportunity. We look forward to any questions. So you can.